Good afternoon, everyone. Thank you for joining us today. My name is Georgia. I'm the Project Support Officer for the Paediatric Integrated Cancer Service, and I will be acting as your moderator for the session today. I would like to begin the session by acknowledging the traditional owners of the land on which we are virtually meeting today, the Wurundjeri people, and pay my respects to elders past, present, and emerging. Today is the second of 4 sessions designed for allied health, administrative and support staff as an introduction to paediatric oncology. In last week's session, we covered paediatric cancer in Victoria and types of childhood cancers. If you missed these sessions or if you would like to take another look, even if you did attend, those sessions are available on our YouTube channel, and we will circulate a link to the recording in the post-session email that will go out to attendees of today's session early next week. Today we will be hearing from Chris Williams, who is the Paediatric Oncology Nurse Consultant and Bob Skilton Outreach Nurse at PICS. Chris will be covering the side effects of treatment and implications for allied health professionals. A little housekeeping before we get started. We will be attending to questions at the end of the presentations today. So we ask that throughout the session, if there are any questions that come up, you submit them via the Q&A button on the bottom of your screen rather than the chat button. If there is anything that you would like to share with the group or any comments that you would like to make, please feel free to use the chat function. Just note that today is an open session and we do have staff attending from multiple health services. So please refrain from including any sensitive patient information in the questions that you ask or comments that you add. Today we will also be using Socrative to test your understanding of the content towards the end of the presentation. You can log in now via the login details on the screen. However, we will provide them again later in the session, so don't worry if you don't have time to set that up at the moment. The quiz will be made up of short answer, multiple choice, and true or false questions, and all of your answers are anonymous. Please note that the slides will also be circulated in the post-session email, along with a recording of the session early next week. So if you would prefer to not take notes and to just listen, then feel free to do so. Now, without further ado, I would like to welcome Chris to take us through the session.
Awesome, thanks Georgia. I'll just share my slides. Okay, so thank you everyone for attending today. So today is kind of part 2, as Georgia said. We're going to talk around treatment and side effects of childhood cancer. I'll put this up again later so we can all have a look at that and do some of the pop-up quiz. So what do we want to look at today? At the end of this session, we want you to be able to recall some of the common approaches to talk about some of the short and long-term side effects associated with treatment, discuss some of these implications this knowledge may have for allied health professionals. And one of the things we put there at the bottom, treatment for cancer is high-risk therapy with a narrow therapeutic index. And what does that mean? It means that, we know we've got to give therapies that can have a high toxicity, and too much will cause a lot of unwanted morbidity, and not enough is not going to treat the patient. So there's this very small window, which we call that narrow therapeutic index, that we worry about. So the treatment modalities, 5 major treatment modalities we see: surgery, radiation therapy, chemotherapy, hematopoietic stem cell transplant, which we would traditionally call bone marrow transplant, and the emergence of immunotherapy over the last 5 to 10 years. For some kids, they may only undergo one, such as a child with low-grade glioma, a low-grade brain tumour. They may just have a surgical resection. For other children, such as a child with stage 4 neuroblastoma, they may actually undergo all these over a long period of time. So the first one, surgery. Surgery is usually part of a multimodal effort. As I said, it can be just a single way of treating, often combined with chemotherapy and radiotherapy. It could be that it's indicated as simple as diagnostic biopsies or staging surgery. Surgeons could be involved in actually debulking or a gross total resection of a solid tumour or a brain tumour. It could be that surgery is required for managing complications of therapy. It can sometimes, rarely, but could be involved for palliation and symptom control. And often for many children, it's supportive care, such as the insertion of a central venous access device, which will invariably be done under anaesthesia in theatre. The second modality is radiation therapy, and we, if you attended the last talk, we had a bit of a YouTube video, which I'd recommend go and have a look at online. I think George has got links to that to talk about this process for children. So radiation therapy is about using high energy particles to destroy cancer cells by breaking the DNA within the cancer cell, and it also reduces the ability of the cell to repair. It's really limited by its late effects, so because it can be very effective on the cancer cell, but the local tissues around it mean that we are very mindful of what are the long-term effects from radiation. And some of the, I guess, more profound long-term effects we see in the late effects clinic are from children that have either had radiation to their brain or to specific organs. Having said that, it is used in up to half of all diagnoses, and radiotherapy is always administered over at Peter MacCallum Cancer Centre. So it is, again, something that's off-site. So we need to keep that in mind for children that are having radiation therapy, that they may need support, they may need transport, and the whole emotional impact of being in a strange environment. The third one we're most obviously familiar with is chemotherapy. So traditional chemotherapy itself is designed to kill rapidly dividing cells. Cancer cells are generally very rapidly dividing, and it's why they're very sensitive to chemotherapy. All chemotherapy protocols are designed and administered according to that child's cancer, their staging, and any of those specific markers. Chemotherapy can be used to cure the cancer, which is our primary objective. It may be utilised to control disease itself, or in some circumstances, we will use chemotherapy for palliation. And palliation chemotherapy is generally going to be therapy that is well tolerated, without a big side effect profile, and preferably that it's given orally and we can keep the child at home. The plans can differ very greatly between patients. So for example, a child with a bone cancer, we talked about this last time, osteosarcoma, they may have long inpatient admissions over several months, whereas contrast with a child with leukemia, they may have very short outpatient or home-based admissions over years. We always use a central line to administer chemotherapy in children, and from an allied health perspective, always remembering cytotoxic precautions. So children that are actually receiving therapy, chemotherapy, are going to have cytotoxic waste, and it's a session we'll talk about. If you log into our session I think it's session 4, Lisa will talk to you about safe handling and waste precautions. The fourth is hematopoietic stem cell transplant. As I said, it used to be bone marrow transplant. It's really been, we call it this word because it's really hematopoiesis, which is the bone marrow factory and where all the blood cells are growing. And it's the stem cells out of the bone marrow factory. So those stem cells are what can then decide to grow up and be whatever they want to be in the blood. There's two particular types of transplants we see. The first one is what we're more aware of, which is the allogeneic transplant. An allogeneic transplant is about replacing the damaged or diseased tissue, such as a child that has leukemia. They may have refractory leukemia and relapse and need to have a new transplant. Or it might be a child that's got a disease of their marrow, such as severe combined immunodeficiency syndrome, where we need to give them a brand new bone marrow. And so the process here you can see on the screen is we collect some cells from a donor, and I guess that's the big difference between them. It's someone else's bone marrow who's had a match to that patient, and that's processed, it's cryopreserved and frozen. The patient themselves then gets high doses of chemotherapy to ablate their marrow or remove their marrow, and we reinfuse the new donor marrow into their bloodstream. The second one is autologous transplant. Often if you work in the inpatient environment, this might be called stem cell rescue treatment. And this is where we have a solid tumor predominantly, or young children with solid tumors that can't have radiation. and we need to give them a really, really high dose of intensive chemotherapy to treat their disease. We know they don't have a disease of their marrow, so we can actually collect their own cells. And so we can process, collect, and freeze their own cells, and then give them a large dose of therapy, whether it's radiation or whether it's IV chemotherapy, and then reinfuse those cells back into them. So what's the comparison? The autologist, or their own cells, the cell rescue of a patient, prevents long periods of low blood counts after intensive chemotherapy. There's a limited side effect profile because it is their own cells, which means they get quite an early discharge. As opposed to the allogeneic, which requires that donor, they're related or they're unrelated. There will be long hospital admissions, there'll be increased morbidity because of the type of conditioning and their time to really regrow that new marrow. And that means they have a high infection risk as well. So two very different types. And the fifth one is immunotherapy. So unlike traditional chemotherapy, which works on any rapidly dividing cells, immunotherapy usually utilizes the patient's own immune system to fight the cancer. And that might be by slowing down the growth and spread of the cancer, or helping the immune system destroy cancer cells, switching them on, making them recognize that's as foreign, and helping the immune system itself do the job. So this includes things such as monoclonal antibodies, checkpoint inhibitors, and CAR T-cell therapy. And CAR T-cell therapy is one that you may have heard of. It's really something that's come out of the last 5 to 10 years and in the last few years here at the Royal Children's Hospital. CAR T-cell therapy just means chimeric antigen receptor T cells. So really what this means is, for our population, it's generally children with leukemia where they're failing, the disease is failing them. They've got relapse, and we're collecting their own cells. We're manufacturing the T cells, and they go into a laboratory where they're engineered and they have genetically modified and then reinfused into the patient. And those new T cells grow and continue to grow and look for disease in the body. And they're really targeted to actually fight a certain type of cancer in that child's body. And we've had some really, really good success with this. And so this is an area of work I think will really open up and revolutionize the treatment of cancer in children, particularly those with liquid cancers and lymphoma. So all those things work very well, but they do have an unwanted side effect profile, and particularly traditional chemotherapy. So one of the first things we look at is nausea and vomiting. Nausea and vomiting can have multiple pathways, and it can be a result of disease. For example, a large brain tumor may be causing raised pressures in the brain and setting off nausea and vomiting. That could also be in the case of a relapse setting. It could be mucositis, and we'll talk about that shortly, but some breakdown in the gut from chemo is causing nausea and vomiting as well. But most of the time, what we're seeing is chemotherapy related. And this includes delayed chemotherapy, chemo-induced nausea and vomiting as well. Sometimes we see it related to radiation, and it's dependent on where the radiation was, can cause that as well. And there's another form we call anticipatory nausea and vomiting, and that's really important to consider as well. This is from a learnt response. And anticipatory nausea and vomiting usually comes as a result of often adolescents or younger or older children that have had a bad, poorly managed episode with nausea and vomiting, and their subsequent cycles of therapy, they'll actually feel sick on arrival to the hospital. What does it mean for allied health staff? So music therapy is really good. Distraction and cognitive behavioral work can actually work very well. Guided imagery, so visualizing images, views outside. Cognitive distraction, whether that's with education, arts, TV, games, crafts, socializing. It's also important to be aware of children suffering nausea may need reduced engagement during these periods of chemo, and often post as well. And from a nutritional point of view, we're always mindful of how the children are traveling, because that can impact on their nutritional intake. And this is the kind of validated tool we've just included. This is assessment with a validated tool we use. I love this BARF scale. You don't forget that. The Baxter Retching Faces scale. It's used in pain management for little kids that really are needing to assess their nausea. Obviously, we know when kids are vomiting, but the key is nausea. And so we use this scale and we try and promote this scale for children, younger children, to rate their nausea. The second one that came out, and this was feedback from the allied health group, wanted to know a little bit about this, is corticosteroid use. So steroids such as prednisone or dexamethasone are really key therapy in some cancer treatments, particularly leukemia. They're probably the #1 treatment to get a child into remission. Steroids are really effective at killing off the lymphocytes, which is the type of leukemia they have, or in lymphoma. Having said that, they do have a pretty decent side effect profile. And one of the things we see a lot is hyperphagia, which is that abnormally great desire to eat a lot. So kids on high dose steroids may gain a lot of weight and want to eat a lot. They can have personality changes, which can be very hard in the toddler age group. Psychosis is rare, but has been documented to the point of severe personality changes. And they can develop, and most children with leukemia at some stage will develop this Cushingoid appearance, where they're getting weight gain in places they normally wouldn't get because of the steroid use, and it means they get a bit of a moon face and lots of weight gain, and that can be hard to deal with as well. So this can impact on attention, it can impact on their learning. Steroid use can significantly affect behaviour. You only have to speak to parents of children that have been treated for leukemia to tell you that. And it can also mean that irritability or personality changes can actually impact on the success of interventions you may be doing in your allied health workspace. It can create challenges for the family, particularly around discipline and parenting. As I said, the nutritional impact and weight gain can be an issue, and dietary behaviours and poor food choices. And so from a nutrition point of view, it can be very challenging, even right through to late effects as a result of the hyperphagia and eating, and particularly eating the wrong foods, because most children on steroids will really want to eat things like salty foods, bacon and chips and stuff like that. The other area from a point of side effect profile is our blood cells. So blood cells grow very quickly, which means, as I said, chemotherapy affects things that are growing quickly, so it affects the blood cell production as well. And we call this myelosuppression, meaning bone marrow suppression from chemotherapy. So bone marrow activity is decreased because of the chemotherapy, sometimes from radiation as well, depending on where the radiation is. Reduced marrow production of platelets, red cells and white cells are the 3 groups that we most worry about. It's important to understand it's not actually affecting those circulating red cells and white cells and platelets that are in our blood, but it's actually affecting the tiny stem cells that are growing and trying to produce into the bone marrow, who are very sensitive to the side effects. And that's why it takes a little while for these effects to take place, and it's usually 7 to 10 days. The first one's platelets, and a low platelet count is known as thrombocytopenia. Platelets are responsible for our clotting of our blood and our coagulation. So children that are requiring platelets may actually present asymptomatic, and we just know that because of their blood tests. However, they may have bruising, they may have nosebleeds, is not uncommon, petechiae, or those tiny little looking bruises on their chest, and bruises in places they normally wouldn't have them. We simply treat that by administering platelet transfusions, and that's generally either in the ward or in outpatient space. So what does it mean for allied health? So if a child's thrombocytopenic, we have to be very careful, particularly in exercise, high impact contact sports and play in their activities. We want to have caution when we're doing interventions such as nasogastric tubes. So a child that might need a tube for feeding, we need to really have an eye on what their platelet count is, and that might slow down the timing of that tube placement. It also impacts on what types of medicines we can have. So one of the things that most younger toddlers will use, parents as their go-to drug, might be ibuprofen for pain or fever. And ibuprofen actually affects the kind of stickiness of platelets by sticking together. So we actually can't use ibuprofen or aspirin during treatment for cancer. So that's another thing to think about. Low platelet counts mean using a soft toothbrush, avoiding, if you're choosing foods that they need to eat, it might be avoiding sharp foods to reduce oral trauma, and avoiding skin trauma as well, such as needles and things when their platelet count's very low. The other area is red blood cells. So our red blood cells are measured by our hemoglobin. A low red blood cell or low hemoglobin is known as anemia. The red blood cells are responsible for carrying oxygen to our cells, and the hemoglobin itself is a protein in the red cell that transports oxygen. And that's what we're measuring when we're looking at what their red cell function is. Signs and symptoms of anemia include things like short attention span, fatigue, shortness of breath, pallor, so pallor of the reduced colour in their face, in their mouth, in their mucosa, in their nail beds. And it's managed with red cell transfusions, again, in an outpatient or inpatient setting. So what does it mean? If their children are anemic, an impact on their school and their learning and education. Many younger children with anemia may be very irritable. They're going to experience a lot of fatigue. Often headaches are present with children that are anemic. So a lot of that's going to impact on their learning abilities. And it's certainly going to impact on their physical abilities, particularly with exertion. So it's one of those things we need to be cognizant of as well. And the third group of the cells that are produced in the marrow, the myelosuppression, comes from the white blood cells. And the main white blood cell count of concern in infection is what's known as the neutrophil. And a low neutrophil count is known as neutropenia. The neutrophils are responsible for preventing and fighting bacterial and fungal infections. And having a low neutrophil count, a neutropenia, puts a child at serious risk of infection, and particularly bacterial and fungal diseases. So the implications are to avoid exposure to other infectious contacts. I think we are working very well in that environment right now. Many families that are on treatment for cancer will actually, and you may have had these conversations, to say that the restrictions from COVID is very much what the life is like of parenting with a child that has profound neutropenia or post-transplant. And it's interesting for us to have a bit of that empathy at times. What other things? Avoiding large public areas for high-risk patients, hospitalisation for very high-risk patients, sometimes regardless of fever, and strict hand washing and attention to hygiene. I think if you're approaching a family that are neutropenic and engaging with them, hygiene and things like that are very important. It's something that parents will be looking to. One of the other areas that we know about is hair follicle cells. They also grow quite rapidly, which means they can be sensitive to the effects of chemotherapy or radiation. And hair loss from anti-cancer therapy is known as alopecia. It's a side effect therapy, as I said, from either chemo or localized radiation. Hair on all parts of the body may ultimately be affected, depending on the intensity of treatment. It usually occurs from about a week following therapy and can resolve several weeks after, and it's not consistent in all patients or all treatments. For example, a child with acute lymphoblastic leukemia may lose their hair during their intensive therapy, but for their 2 years of maintenance, they may have a full head of hair and it all grows back. So there's some psychological distresses they're experienced for some children. It doesn't seem to be the stigma that it used to be traditionally. And predominantly it may be the adolescence and body image that we will be working on in altered and changes in body image with alopecia. The other part of the body that is impacted on chemotherapy is gastrointestinal cells. So the cells lining the gastrointestinal tract, when they get inflamed and causing pain and damage, is known as mucositis. Mucositis is one of those highly rated side effects of chemo, particularly in the adult world, is one of the most debilitating side effects of treatment. That lack of a normal barrier in our gastrointestinal tract results in inflammation and proceeds to sometimes be ulceration and pain. It can often be caused by children that are having radiation in that field of area in your gastrointestinal tract, but more often it's the side effect of some of the chemotherapy agents we give. Not all of them, but many of the solid tumour patients most at risk, and high dose intensity protocols during leukemia treatment, and all of the bone marrow transplant conditioning will have some degree of mucositis. This can result in pain, it can result in malnutrition, dehydration, nausea, and definitely reduced health-related quality of life. It usually starts to occur, that breakdown in those cells, about 3 to 5 days after treatment. The normal cells lining the GI tract rapidly divide. So once they die from the therapy, it takes a while for the others to start to grow, and that's when we start to see the visible signs. And the visible signs of mucositis are sometimes about a week to 2 weeks after treatment. One of the other things here, just as a point to think about, is host factors. Children with Down syndrome are very sensitive to mucositis, and they also have a very high pain threshold usually. So it's really important, if you're looking after Down syndrome patients and doing interventions with them, to think about the degree of mucositis they may have. Close monitoring and the need for enteral and parenteral nutrition. So obviously dietetics and nutrition are very involved with patients that are having a lot of mucositis because we need to support their nutritional needs. And we also need to appreciate the need that sometimes pain management can be with patient-controlled morphine-based analgesics and can be very debilitating pain. And there are some sensory changes from chemotherapy as well, such as what we call neuropathy, which is damage or changes, altered sensation in our nerves, peripheral nerves in particular, such as motor skills or touch or feet, the ability to walk well, tingling in the toes and feet, or central neuropathy, such as constipation. And these are generally chemotherapy related. Visual changes could be from chemo or from disease and related loss of visual potential. Hearing loss from chemotherapy, particularly high frequency hearing loss in many children that get platinum-based chemotherapy. It's a late effect that they live with and is permanent. And taste, about 20% of children actually undergoing chemotherapy will report some change in their taste in food. And so that can impact from a nutritional point of view as well. Being aware of sensory loss can help tailor our interventions and help appreciate that emotional effect. Fatigue is also a very frequent and distressing symptom that's experienced, and it's often treatment related, change of environment and lifestyle, and the emotional changes. And fatigue, yes, we're talking about the child, but fatigue is also there from the family as well. There's limited effective preventative strategies available, and we know though that it can continue right through survivorship. Steps to managing fatigue in children with cancer can though often be supported by the allied health team, such as daily exercise, a good nutritional plan, and the supportive strategies for reducing stress in the child and in the family. And there's also a lot of late effects that we need to consider. So most of those we've talked about here about those direct immediate effects, but the late effects of childhood cancer can be significant. And those late effects are what will actually help often define a treatment plan by avoiding those long-term complications during a child's growth and development. And some of these on this little figure here, you can see memory loss, learning disabilities. So a neuropsych team is very much involved in this. Hearing loss, as I talked about, is going to impact on child's growth and development significantly. Often they'll experience more cavities. Children that have radiation or chemo at a very young age may have teeth that just don't grow and have absent teeth or teeth that are very, in the late effects, that move quite a lot. Many treatments will have therapies that result in heart damage to a small degree, and they may be on having regular cardiac echoes and cardiac consultations for years. Some of that nerve damage may result in long-term permanent nerve damage, and we need to look at that from a rehabilitative point of view. And although we didn't touch on it a lot, there is a degree of infertility and issues with puberty as a result of treatment as well, whether that's from radiation to that area or radiation to the brain. Secondary cancers is something to think about in late effects as well. And we look at that particularly for children that have had brain radiation or total radiation from transplant. And there's stunted bone growth. So again, often this is from treatment related from brain tumors and growth and development. And so that is a late effect that will look at growth hormones and things as they get older. So we have some vignettes that we usually involve you guys when we're face to face and we're not muted and we can all have a chat, but I'll go through these because I think they're important to just put some context to some of this work. So this one here is Ben, and Ben's a 6-year-old boy who's received vincristine for his treatment of his brain tumor, which is a type of IV chemotherapy we'll give. Ben's parents report he's become very irritable recently and difficult to console. He's often rubbing his stomach and looking at his fingers. The nurse notices this, that Ben has been having difficulty with his fine motor skills, and she uses a pain face scale, and Ben points to the sad face, indicating pain in his hands. After spending some time playing and talking with Ben, it's determined that he has pain in his abdomen and in his fingers. Ben's subsequently diagnosed with central neuropathy with constipation and peripheral neuropathy from that fingertip numbness. A stool softener medication started for his constipation and educating the family around his fluid and fibre intake. And he goes on to a gabapentin medication to help with that numbness in his fingers. And we'll continue to monitor that at subsequent clinics for his neuropathy. And our second case here is Julia, an 11-year-old girl diagnosed with acute lymphoblastic leukemia 3 months ago. Before her diagnosis, she was a really active kid in dance classes and gymnastics, taking classes 3 times a week. Her mum describes her daughter as never lacking energy and always engaged in some type of physical activity before her diagnosis. And since then, she's complained of being tired all the time. She had to quit her dance and gymnastic class. These kind of significant impacts on their normal lifestyle of things that they really enjoy doing, we need to think about. Her mum states she's having trouble sleeping and wakes several times each night to go to the bathroom. Julia returned to school a month ago, but continues to miss 1 to 2 days a week because she's so tired. They meet with the healthcare team in the cancer clinic and they discuss these feelings as being common in children on chemotherapy for leukemia. They talk about ways to minimise that fatigue, including frequent rest periods, daily exercise activities, good nutrition strategies, and ways to reduce the stress of treatment. And that's not an uncommon scenario, and it's important that we actually intervene and support that, particularly for children that are missing lots of school. So in conclusion, childhood cancer, its treatment, its related medical procedures can result in a wide variety of side effects. This is a small amount of what we may see, but it's really looking at the more common things that may have impact on your care. These side effects disrupt a child and family's life, they create complications, and often they can even compromise treatment. And as I said, we often will be designing treatment plans that actually align with reducing those side effect profile. Children with cancer often report treatment-related symptoms as the worst part of their cancer experience, and these are things that are often remembered long after cure. Not the treatment itself, but some of those side effects, particularly things like mucositis and pain. Appropriate recognition and interventions can improve those outcomes, enhance the quality of life for children with cancer, not just for them, but for their families as well. I've just snuck this in because I'm not sure whether we put it in last time, and apologies if we did last time. But for looking at some further learning, if you go to Apple Podcasts and look at Jeff McCowridge's work, who's a paediatric oncologist at Westmead, log in and you can download a lot of these podcasts. There's a lot of work in these podcasts around different side effects of treatment where he might spend 10 or 15 minutes talking about one. There's about 60 podcast episodes, 70 episodes in there. And I would certainly look at those as a way of further learning as well. Right, I'm going to hold this screen up for about half a minute. We have a few questions to go before we finish our session today. So if you grab your phone or your PC, log into socrative.com. When you log into socrative.com, there's a login button. You need to press student login. And when you go into student login, that requires a room name. The room name we have there is Williams 5291. That's Williams 5291. I'll just hold that there for a minute. I'm just going to open the Socrative page now, so we'll just stop this share. And we've got a few questions to go through. So a bone marrow transplant, where a patient receives their own cells, is known as what? Yep, an autologous transplant. And so these are what we might often use during periods of solid tumour treatment, such as neuroblastoma, where they might get 1 or even 2 of these during their therapy. Traditional chemotherapies designed to kill rapidly dividing cells. And this is I guess the crux of everything we're talking about today with side effects. Most of this stuff we're looking at is driven by traditional chemotherapy. So it's killing those rapidly dividing cancer cells, but it's also affecting their cells in their marrow, in their gut, their hair, their fertility. What intervention here is not a common treatment modality for cancer in children? Hormonal therapy. So hormonal therapy is used a bit in the adult world, certainly not as much of a thing we would use in children. Okay, the following image describes what kind of transplant. Yeah, so it's definitely a stem cell transplant, but we differentiate this from those because we're getting a donor. It's an allogeneic transplant. It's just important to know there's two types of transplants we're using. The language changes. Predominantly now you'll see HSCT in the notes. That just means hematopoietic stem cell transplant. Same thing as what we used to call it as a bone marrow transplant. So neutropenia primarily places the child at risk of what? Infection. And neutropenia, in times of neutropenia, what do cause a lot of anxiety in parents as well, and particularly about us and our way we're looking after families and hygiene. And again, Lisa will talk about some of that stuff in an upcoming session around the care of children with neutropenia precautions. When managing the child with a low platelet count, what should the health professional do? Yep, and I like to someone's put that nasogastric tube session was we're really keen on that one. We really need to know what their platelet count is of that. And if you work in nutrition, you know, you work with us a lot on figuring that out. But there's a lot of reasons there why we need to be mindful of children with their low counts. When a child is anemic, it may impact on their level of concentration. Is that true? Yes, it's something to be mindful of. And sometimes what we would certainly do is we have a kind of rule that if a child has a hemoglobin less than 70, they buy themselves some blood cells, some red cells. However, some children, particularly adolescent boys, will maybe a little bit higher than that and actually have symptoms. So a child with a hemoglobin under 80 but has a symptom such as they're not concentrating well, they've got headaches, they're short of breath, may actually get some red cells as well. And a medication that may increase a child's appetite and affect personality change. Steroids, excellent. I think many of you who particularly have managed children with leukemia or been involved with children with leukemia may know this. It's a topic of conversation, happens a lot with parents. All right, we're finished there. I'll complete that. Thank you again so much for your time, and I'm going to handball you back to Georgia. We'll see if there was any questions at all, and I'm happy to answer.
We only had one question come through via the chat, just asking what is considered a low neutrophil count. I have just added a response in there, Chris, which you'll be able to see. I don't know if you want to add anything to that. I can circulate that link to the clinical guideline in the post-course email that goes out as well. And we do have some more information and an e-learning module available via the PICS website, which I can circulate with everyone.
Yeah, no, that's certainly the case. We really start to worry with a neutrophil count less than 500, or in our pathology system of the children's, that'll be 0.5. Anything under 1 is considered neutropenic, but definitely under 0.5 is where we would be starting to get concerned. But yeah, that's excellent. I think that there is certainly the guideline there in the e-learning module for people to learn about that.
We've just had another question come through. So is there any link with treatment and risk of avascular necrosis sites?
Yes, so avascular necrosis can come from the use of steroids. Steroids, even though they're this little syrup that they take as an oral medicine and work very effectively for leukemia, can have significant issues. And one of the issues can be necrosis in the bone itself, particularly in knees and hips, as a result of long-term use of steroids. And so that is something that is kept a close eye on between physio, oncology, and dosages, and particularly in the adolescent group, where they've actually moved to use dexamethasone as opposed to traditional prednisone because of that risk of avascular necrosis. And that happened quite a few years ago now, but we still see that as an issue, particularly in the adolescent group, as a late effect.
Okay, I don't think there's any other questions at this stage, so we might wrap up a little bit early. I'll just remind everyone that the next session is next Tuesday, the 20th, from 9:30 to 10:30 a.m. We will be hearing from Maria McCarthy on the psychosocial impact of childhood cancer on patients and their families. We'll circulate a link along with the post-session email to sign up for that session if you haven't already. And as always, if there are any questions that come up, or if you want to get involved with any of the work or attend any MDMs or have a tour of any of the cancer centres, as we mentioned in last week's sessions, feel free to get in touch with us via the PICS admin email address, which is pics.admin@rch.org.au. You see, we've just had another chat come through. It's not a question, just thank you very much. Thank you. So thank you, Chris, for speaking today, and thank you everyone for attending. We hope you have a good rest of your Friday and a great weekend, and we'll see some of you next week.
Thank you very much, guys.
Thanks.
Bye.
Bye.